Adenosine is a naturally occurring nucleoside. A nucleoside is a molecular structure consists of a nitrogenous base attached to a pentose sugar, either ribose or deoxyribose. It lacks a phosphate group. Nitrogenous bases are organic molecules containing nitrogen. These are the fundamental component of nucleic acid. In the structure of the DNA, there are different nitrogen bases. One of them is the adenine. When a ribose molecule is added with the adenine, the adenosine is formed. The nucleoside adenosine is then used to form a nucleotide that is found in the DNA and the RNA molecule. Adenosine nucleoside is also formed the ATP, AMP, cyclic AMP, ADP. Adenosine is a class 5 antiarrhythmic agent. It is used for acute termination of reentrant supraventricular arrhythmias. Pharmacological effects. The action of adenosine is mediated by interaction with a specific G protein coupled adenosine receptor. We can find adenosine receptor throughout the body. The adenosine receptor which found at the cardiac AV node is the A1 receptor that slows down the impulse transmission. Thus, it increases the refractoriness of the AV node. And the adenosine receptor which found in the endothelium is the A2B type of receptor that causes relaxation of the smooth muscles of the vessels, mainly the arteries, that causes the vasodilation. Adenosine causes shortening of action potential duration, shortening of hyperpolarization, and slowing of normal automaticity. This is produced by activation of acetylcholine sensitive potassium current in the atrium, SA node, and the AV node. During sympathetic stimulation, there is increased intracellular cyclic AMP formation. Increased level of intracellular cyclic AMP increases the contractility of heart. Adenosine also inhibits the electrophysiological effect of increased intracellular cyclic AMP. Adenosine also reduces calcium current. This leads to increased AV nodal refractoriness, and it also inhibits delayed after depolarization elicited by sympathetic stimulation. Administration of intravenous bolus dose of adenosine causes slowing of sinus rate, slowing of AV nodal conduction velocity, and increased the AV nodal refractoriness. A bolus of adenosine can produce transient sympathetic activation by interacting with carotid baroreceptor, whereas a continuous infusion can cause hypotension. In the heart, adenosine binds to its receptor, that is A1 receptor. The adenosine receptor is coupled to inhibitory G protein on the nodal tissues. This activates the inhibitory G protein, which in turn inactivates the activity of adenyl cyclase. This leads to reduction in the cyclic AMP and pKa activity. This reduces the influx of the calcium into the cell and increases potassium efflux out of the cell, which causes SA node cell membrane to hyperpolarize. The end result is to slow the nodal conduction. Therefore, antiarrhythmic effect of the adenosine is by delaying the action potential in the SA node and by increasing AV nodal refractoriness. Adenosine can also be used to produce controlled hypotension during some surgical procedures and in the diagnosis of coronary artery disease. In this case, adenosine used as a continuous infusion. The action of the adenosine is short-lived because it is eliminated by carrier-mediated uptake in most of the cells, including endothelium. The drug is transported into the cells and deaminated by adenosine deaminase so rapidly. Side effects. As the action of the adenosine is short-lived, thus the adverse effects are also short-lived. There is transient asystole that usually lasts for less than 5 seconds. Most patients feel a sense of chest fullness and dyspnea when therapeutic doses of adenosine are administered. Rarely, an adenosine bolus can precipitate atrial fibrillation, may be due to by heterogeneously shortening of action potential of the atrium. It may also cause bronchospasm. The therapeutic dose of adenosine is 6 to 12 mg. The dose of the adenosine is depend upon whether the drug is given via the peripheral vein or via the central vein. When the drug is given via the peripheral vein, the dose is 6 mg IV bolus. If the tachycardia is not corrected, then the drug can be repeated 12 mg. If still not terminated, then again repeat the drug with 12 mg. When the drug is given via the central line, as the central veins are very close to the heart, lower dose is required. First dose is the 3 mg IV bolus, then the 6 mg, followed by 9 mg if needed. The total 3 doses are there. When it is given by the peripheral vein, it is the 6 12 12, and when it is given by the central vein, it is 3 6 9. In case of the cardiac transplant patient, as there is denervation hypersensitivity, the adenosine dose reduces further. The dose is 1 mg IV followed by 3 mg. If not terminated, then again 3 mg. So maximum of 3 doses are given. It has half-life of a few seconds. The action of the adenosine is so short-lived that a rapid bolus dose is required for its efficacy. Slow administration results in elimination of the drug prior to the arrival at the heart. The effect of adenosine are increased in patient who is receiving dipyridamole, as the dipyridamole is an adenosine uptake inhibitor. Its action is also increased in patient with cardiac transplant due to the denervation hypersensitivity. Methylxanthine, such as the theophylline and caffeine, that block the adenosine receptor. Therefore, larger than the usual dose are required to produce the antiarrhythmic effect in these patients who have consumed these agents in beverage or as a therapy.